Let's start with the first presenter. This is Shannon Melissa Khan from the Prince Waits Hospital of the Chinese University of Hong Kong. And she will talk about her research work on the use of over-the-scope clips OTSC versus standard therapy for the prevention of rebleeding in high-risk peptic ulcer patients, a randomized controlled trial. Please, Shannon.
Good afternoon. I'm Dr. Shannon Chen from the Chinese University of Hong Kong. So thank you very much for the opportunity to present at the Endo-Swiss Young Talent Award. So the project I'm going to present today is one of the first projects I did as a principal investigator with the title, The Use of Over-the-Scope Clip versus Standard Therapy for the Prevention of Rebleeding in High-Risk Peptic Ulcers, a randomized controlled trial. So rebleeding occurs in 15 to 20% of high-risk peptic ulcers. Recently, OTSC has been used for primary hemostasis. So the aim of this study is to compare the efficacy of OTSC to standard therapy in primary treatment of patients in peptic ulcer bleeding that are of high risk for rebleeding. So this is a prospective, open-labeled, multi-center randomized controlled trial. Recruited patients were randomized to receive OTSC or standard endoscopic therapy. The centers include our own center from Hong Kong, a center from Thailand, 2 centers from Taiwan, and also a center from China. We included all patients who had actively bleeding peptic ulcers with ulcer size more than or equal to 1.5 centimeters. We excluded all patients with peptic ulcer with concomitant perforation, tumor bleeding, and variceal bleeding. The primary endpoint of this study is clinical rebleeding within 30 days. Secondary endpoints include death from all causes within 30 days, transfusion requirement, hospital stay, failure of achieving primary hemostasis, and further interventions that are needed. So in a previous study studying the use of prophylactic TAE in high-risk peptic ulcers, we found that the rebleeding rate of ulcers of more than or equal to 1.5 centimeter without TAE was 23.3%. So we assumed that OTSC would reduce rebleeding rate from 23% to 5%. Using a two-sided log-rank test with 5% significance level, 100 patients is required to achieve an 80% power. So crossover is allowed, meaning that if patient is randomized to the standard group and if failed primary hemostasis, the endoscopist is allowed to cross over to the OTSC group, and vice versa. So here are the results. So in a 3-year period, we completed the study with 50 patients in each group. In terms of baseline demographics, they were similar in terms of age, gender, forest classification, size of ulcer, and the location of ulcer. We recruited 100 patients. In the 50 patients in the OTSC group, technical failure happened in 4 patients. And in these 4 patients, 3 out of 4 of them rebled, accounting to a 75% rebleeding rate. 46% had successful technical application, and a rebleeding rate was 4.35%. An overall rebleeding of 10% was resulted in the OTSC group. In the standard group, 2 patients failed primary hemostasis and crossed over to OTSC, and there were no rebleeding. 48% had successful technical application of standard therapy, and rebleeding rate was up to 18.75%. An overall rebleeding rate of 18% was resulted in the standard arm. As a result, in the ITT analysis, there is no difference in clinical rebleeding within 30 days between the 2 groups. So this is a Kaplan-Meier curve showing the results. So the red line is a conventional arm, and the blue line is the OTSC group. So you can see that after the log-rank test performance, the p-value is 0.234, which shows non-significant result. But this may be due to a type 2 error. So the secondary endpoints of this study, including death, blood transfusion, hospital stay, failure of achieving primary hemostasis, and the need for further interventions were not significant. So we know that 4 patients had failed primary hemostasis, that is a technical failure in the OTSC group. So if we focus only in patients who had technical success as a primary hemostasis in each group, we found that for the OTSC group, the rebleeding rate was only 4.35%. And in the conventional arm, the rebleeding rate was up to 18.75%. In the log-rank test, this shows significant result, meaning that if OTSC is successfully applied, then it can reduce clinical rebleeding within 30 days. So in the 4 patients who had failed OTSC application, they were all located, the ulcers were all located in the D1-2 junction, which is a difficult position. They were all salvaged with heater probe and adrenaline injection. So 3 out of 4 of them had rebleeding. The one case who did not rebleed received empirical TAE. In the conventional arm, the 2 patients who failed primary hemostasis were converted to OTSC and there were no rebleeding. So with this, I would like to conclude our study in that in these large bleeding ulcers with a size of more than or equal to 1.5 centimeter, in the ITT analysis, OTSC unfortunately did not decrease clinical rebleeding within 30 days when compared to standard therapy. But we know that technical expertise is highly required in the application of OTSC, especially in the D1-2 junction, because technical success of the application of OTSC is associated with significantly lower rebleeding rate. So with this, I would like to thank our collaborators from Thailand, Taiwan, and China. Thank you.
Thank you, Shannon. We have one question to you. You mentioned these 4 cases of unsuccessful deployment. So it was a technical issue, or the clip didn't grab the tissue? What was the reason? Maybe you can tell us again the situation with the 4 unsuccessful cases.
So hello, Stefan. Thank you for your question. It's very nice to see you again. For the 4 cases who had technical failure, they were all applied by specialists. So, they had all the experience of more than 20 application of OTSC. For all the 4 cases after application, it was the vessel was only grasped half, and the other half was still exposed, and so there was persistent bleeding, and so further hemostasis was required. So all 4 cases, the persistent bleeding was noted in the index endoscopy, so they were classified as technical failure.
Thank you, Shannon, for this very good presentation, and Stefan will present the next talent.
Thank you.